We are all eager to listen to your second lecture about differential diagnosis of left ventricular hypertrophy, a common finding in HFPEF.
Yeah.
Are you ready?
Yeah, you give me some stress. I look for the next one. I hope that works now, because as I had prepared the talk for you, suddenly I got a shutdown of my computer. Everything was lost, and I just tried to my best to give that what I could save, but the rest I do just as I do it. So where we are, like here. So again, my question, do you see my talk and everything is fine?
Yes, sure.
Okay, so that you know already. I just told you that we have an HFPEF algorithm and score, and now we would like to go. So dear colleagues, now technique works again. I have now the task to discuss with you differential diagnostic in left ventricular hypertrophy, a common finding in HFPEF, and I think that's extremely important to discuss that, to think about the differential diagnoses. That you know, I'm a fan of the HFPEF algorithm of the HFA Society, the Heart Failure Society, and we just had discussed the stepwise approach of the HFPEF algorithm. We wanted to have first the pre-test assessment, then we came up with a specific echocardiographic natriuretic peptide-based score. We discussed the role of an on-top stress test, and now we discuss the etiology workup. So I would say in 80% of the patient HFPEF, we believe the etiology is clear. It can be hypertension, diabetics, obesity, and so on and so on. But in about, let's say, 10 to 15%, the patient have a HFPEF-like syndrome, but they do not belong to the patients with hypertension or obesity. They have, for instance, genetic disorders and an abnormal left ventricular hypertrophy. And therefore, they ask in the guidelines to really prove the final etiology. It can be possible that you need a genetic test, that you have infiltrative storage diseases in front of you. It can be a myocarditis or consequences, for instance, of cancer drug therapies. So my first question is, what is the normal left ventricular size? And I believe that is extremely important. This is an analyzing 15 years ago in sportive, healthy patients. And you see that a normal left ventricular size is about 10 to 11 millimeters, 12 in rare sizes. So everything what is here higher than 30 is already an exception of about 2%. So when we speak about left ventricular hypertrophy without hypertension, and even if the patient would have hypertension, it is rare that you see 30 millimeter walls. Everything what is higher than 12 to 30 millimeter walls, you should think about that there could be something in addition. And the left differential diagnosis in left ventricular hypertrophy can be hypertension with an hyperaldosteronism, can be aortic stenosis, probably myocarditis due to the edema. But I think the three most important, which we should not overlook, are the hypertrophic cardiomyopathies, the morbus Fabry, and the amyloidosis. And I come up with a case. Let's say a 50 years old patient. He has already 2 cryptic transitoric attacks, or 1 in apoplex. Left ventricular hypertrophy is 40. Ejection fraction is 50. He has dyspnea, Neuer class 3, diabetes, and he has neuropathy of the legs. BNP is also increased. What do you believe? But what do you believe? It is heart HFPEF plus a genetic myopathy. So, okay, ejection fraction 50, dyspnea, a little bit left ventricular hypertrophy. But how do you explain the neuropathy of the legs and the 2 cryptic TIA? Does that belong together, or are these 2 different diseases? What about to say, hey, that could be a hypertrophic cardiomyopathy? The transitoric attacks have nothing really to do with that primary. Probably had sometimes atrial fibrillation, and the neuropathy in the legs, that belongs to the diabetes. Possible? When we think about hypertrophic cardiomyopathy, this is the highest genetic disorder in human beings. In cardiology, it means 1 to 500. Etiology is that we have a genetic disorders in the sarcomere. And look at that, I really love this slide. There are so many forms of hypertrophic cardiomyopathies, which you see here from A to J to E to D. Let's think about what is important. And I think the asymmetric form is the most important one. You see that here, that you have an enormous septum hypertrophy. The hypertrophy can be subarterial, diffuse, local, or even on the free wall. This is with 70% the most common form. Has a septal thickness higher than 15, is extremely important. Injection fraction is normal to hyperdynamic. Important is the fibrosis under that kind of conditions. And I think the treatment here is clear. You cannot come up with an ARNI. That would not help. If the left ventricular obstruction delta is higher than 30, probably the best way is come to here with a TESH to reduce the obstruction of that kind of scenario. I think this is important to think about and to look to the walls, what kind of hypertrophy is in front of us. Even the patient would have HFPEF syndromes like dyspnea. He would have thicker walls, he would have a high BNP, but treatment and disease is quite different. I think it is a simple case, but you have to think about that this is a HFpEF-like syndrome, but not that what we would really call HFpEF. We can have also concentric hypertrophy. This is the second common form, supernormal ejection fraction, diffuse left ventricular hypertrophy, and sometimes it is difficult to get the differential diagnosis to the heart of a sportsman or to hypertension. But hypertension usually never have higher than 50 millimeters left ventricular hypertrophy and would have, of course, a normal left ventricular end-diastolic diameter. Don't forget to think about storage diseases. About that we come a little bit later. Apical hypertrophy, I really love that. You see that here from the card games, looks like that. And you very often in the EKG, you have here these ischemia signs. We call it the Yamaguchi syndrome. A lot of angina pectoris symptoms this patient have due to the high wall stress, and the stroke risk is high. So remember, the patient before, he had high wall thickness, normal ejection fraction, left ventricular hypertrophy of 14, and he had strokes. Can be due to AFib, but can be also that you have apical aneurysms and that kind of conditions. And you see that here, stroke risk is high due to the end-stage aneurysm formation and that kind of conditions. Last but not least, but I think I love to show you that, is the mid-ventricular form of hypertrophic cardiomyopathy. So the volume left ventricular outflow tract is free, but you have this hourglass phenomenon, and there's no SEM. The alpha ATT is free, but still the patient has that kind of symptoms, as you can see here, under that kind of conditions. If you don't take care, if you just do it by echo and see, okay, and the apical, there's a little bit thickness, you would oversee that. But here you have a high risk of embolic stroke and sudden death. And the patient would present as an HFpEF-like patient. Now we have the same patient in front of us, but we could not come up with a diagnostic of hypertrophic or hypertrophic obstructive cardiomyopathy. What about morbus Fabry? Morbus Fabry is a disease with sphingosine lipoid accumulation due to gene mutations. Very often the gene mutations also induce neuropathology, tears, and peripheral neuropathy. So if you see that here, normal ejection fraction, left ventricular hypertrophy, he has cryptic transitory attacks, and he has also a peripheral neuropathy. It could be also morbus Fabry. And that you see especially in the echocardiography with a very prominent papillar muscle. That is extremely important to get it. As I said already, morbus Fabry, even rare, but don't overlook that, is an X chromosomal mutations where sphingolipids suddenly are accumulated in a lot of organs, not only the heart. Some have it more in the eye, more in the brain, more in the kidney, but this accumulation leads to an increase of wall thickness and a form of hypertrophic cardiomyopathy and HFpEF. Important, and that I really have to learn. in 11 to 15% of the patients, male or female, they get a transitory attack even when they're relatively young, 30 or 40 years old. So what I would like to show you here, if you have a young patient in front of you and there's a cryptic transitory attack, and you see that they have a left ventricular hypertrophy, let's say 13, that could be enough. Think about the morbus Fabry approach, and that is really easy to test by a blood test. And again, last but not least, in the larger stages, you see here an increase of a very prominent papillar muscle by a concentric hypertrophy. What about the same patient and you think about another differential diagnosis? What is about amyloidosis? There we also can have apoplex or transitory attacks and also a peripheral neuropathy. You see that here in echo, I think it is so far interesting that you see already this form of sparkling in the left ventricles here. And sometimes you see also that the atrium, if you would do here a strain analyzing, is already impaired in the contraction. So I had been asked, what about strain analyzings in the atrium? I don't believe that we need it in the score, but in that kind of diseases, and you are able to have that, it could be an additional information. However, excuse me that this is a German headline. As I told you, my talk had been crashed just before. I could not translate everything. These are the hallmarks of amyloidosis. Blick diagnosis means view in the first second, normal ejection fraction, concentrated hypertrophy with this sparkling, and that is important. You have a low voltage in the EKG. Why is this so important? Now, what I expect would be that if you have a left ventricular hypertrophy, in the echo I would expect, for instance, a positive Sokolov sign. Since amyloidosis is a storage disease, we have a hypertrophy not according to the hypertrophy of the myocytes, but due to the accumulation of amyloid. And this is not represented by electrical changes, and therefore the mismatch between hypertrophy and a normal EKG is something what I believe is important in that kind of conditions. Again, polyneuropathy is important. So that would fit to that what I have shown you, left ventricular hypertrophy, but also polyneuropathy. You have to think about diabetes, for instance. You have to think about morbus Fabry, but it belongs also to the amyloidosis forms. The largest amyloidosis form, which we have, the highest one, is the wild type, this form in old men. And I believe if your patient has hypertrophic cardiomyopathy and has, for instance, a positive carpal tunnel syndrome, this is high specific for amyloidosis disease and should be treated with tafamidis under that kind of conditions. And if you ask me, what is very, very often in the HFPEF population, then I can say you the most highest incidence of HFPEF in our population, this is the cardiac amyloidosis according to the TTR-related amyloidosis. This is in about 14% of the cases. And the nice thing is it can be treated with tafamidis. So when I take together, we have a large cohort of patients who have another form of etiology than just hypertension and obesity. The high chance and the differential diagnosis are those who represent left ventricular hypertrophy. This is the hypertrophic cardiomyopathy or the hypertrophic obstructive cardiomyopathy. I believe it is not so easy to overlook, but the differential diagnosis to the amyloidosis is extremely difficult. To modify, and therefore I would like to show you the clue how you can differentiate between an hypertrophic cardiomyopathy due to a genetic mutation or due to an amyloidosis. Usually we just use here the TCT scintigraphy which shows you that the ATTR amyloidosis, so this is nothing more than a bone scintigraphy, is suddenly positive and shows you that the left ventricular hypertrophy belongs to the cardiac amyloidosis form, negative in A forms, but that what I believe is extremely important if we think about HFpEF. So, dear colleagues, I come to my conclusion. When you have the HFpEF symptoms clarified by the echo score, for instance, think about the etiology, especially when the wall thickness is higher than 13 or 14. This is unlikely that it belongs to hypertension or diabetes. This should be an alarm signal for you that you go deeper and ask for classical cardiomyopathies, which are just mimic HFpEF. They have a HFpEF-like syndrome, but they need another treatment. Hypertrophic obstructive cardiomyopathy in the differential diagnosis to amyloidosis is extremely important. Morbus Fabry is relatively rare. Don't forget that also myocarditis or post-myocarditis syndromes can also mimic a HFpEF-like syndrome, and therefore I think you have to do an MRI to get the differential diagnoses. At that part, I would like to end and happy for some more of your questions. Thanks for your attention.
Thank you very much. Very nice lecture. Can I ask about the differentiation of athletic left ventricular hypertrophy from pathologic athletes? If you find
can you say it again? I could not hear you.
Athlete exercise, if athletic person.
Yeah, I think that is important. So even an exercise patient, the wall can be a little bit thicker, probably 12 millimeter, but never 14, 15, or 20. So don't come up and tell you that the man is coming and said, hey, I'm belonging to the Egyptian Olympic theme. He never will have 14 or 15. That's for sure not. So 13 is somebody who is doing a triathlon sport is already rare. I believe that even in sportive patients, the most of them should have not more than 11, especially when they are young. 10 is normal. What you see here is that left ventricular end diastolic and right ventricular end diastolic pressure can be a little bit increased. BNP will be normal, but everything what is higher than 13, this is a rare chance that really this belongs to Olympic sport training programs. Probably the patient had eaten some pills that he can be a member of the Olympic game, but then he has already disease in his ventricle. And BNP should be, of course, normal.
Thank you. My question about the cardiac amyloidosis is often missed and called a phenocopy of heart failure with preserved ejection fraction. As we know, there is two types, the transthyretin cardiac amyloidosis and the immunoglobulin light chain. Do you think that we have to do for the patients when we suspect the SPECT technetium scintigraphy or the serum light chain test for the diagnosis, and to whom we screen for the amyloidosis?
Yeah, very important question. So I think if you do an echo and you see left ventricular hypertrophy and you see this sparkling, and you see that also the EKG's Sokolov index is missing, you should think about a cardiac amyloidosis. And you're absolutely right, there are two forms. One is cancer. This is the AL, the light chain amyloidosis. There you have to react immediately. It means that in the 7 days, you have to have the diagnosis and to deal with your hematologist. And this is a different disease, and if you do their light chain analyzings, bench-Jones proteins in the blood test, and this is positive together with the M gradient, I believe this is extremely clear that the patient has probably an AL amyloidosis or plasmacytoma. You can do here, in addition, a bone scintigraphy, which will be in the LA amyloidosis negative, just to be sure. In the AL amyloidosis, left ventricular hypertrophy is not so prominent because it's a form of cancer and the disease already starts relatively early with symptoms and is not only attacking the heart. In the ATTR amyloidosis, this is a liver transport protein disease. There, over the years, the centuries of the patient, since he is born, amyloid is accumulated also on the heart, and therefore, usually we detect the disease too late in old men. Left ventricular hypertrophy is already severe, 15 or 20 millimeters. You have this sparkling, and if you do the bone scintigraphy you ask for, and in the blood test you have excluded Ben-Jones proteins and the M gradient, the disease is relatively clear. So I don't know how is the reimbursement in your country, but the bone scintigraphy is really cheap. It cost me only 80 euro. And the interesting part here is that the calcium sensitizer for the bones is also detecting the ATTR amyloids, but not the ALs. And therefore, the bone scintigraphy allows you, really elegant, to differentiate between an AL amyloidosis and an ATTR amyloidosis. So in my country, it is a must. Have the scintigraphy plus the Ben-Jones proteins, and then you know what kind of amyloidosis is in front of you. In AL amyloidosis, you need a chemotherapy in the next 10 days. In the ATTR amyloidosis, we have drugs available like tafamidis.
The second question also regarding the amyloidosis. The role of anticoagulant, oral anticoagulant in amyloidosis, especially in patients with sinus rhythm.
Yeah, so in sinus rhythm, we would not go for any anticoagulations. So we would have here the same criteria we would have for other patients with atrial fibrillation, except, and that's important, but still nothing what you can read in the guidelines. The CHAS-VAS score is here not working. The CHAS-VAS score is profiled for patients with classical risk factors, but in patients with hypertrophic cardiomyopathy and in patients with amyloidosis, they have a higher risk for thrombosis. The CHAS-VAS score is not working. Therefore, I would say in a patient with amyloidosis and atrial fibrillation, even CHAS-VAS score would be very low. Usually is not low. Patients are usually old and have comorbidities. But just in case, I would give them a NOAC. But if they have sinus rhythm, I would not do so.
Thank you very much, Professor Tschope, for the great lectures we've had today. And hopefully we see you in person very soon in Egypt. Thank you.
Thank you for attention and your patience and for great questions. You really listened very well and had the fingers in the wand.
Okay, thank you. Bye bye.
Bye bye.
احنا كده جينا وصلنا لاخر البروجرام وارجو انكم تكونوا استفدتوا وان شاء الله نلتقي على خير. شكرا.